Good evening. Welcome to the second session of the Outbreak Control Strategy course. Thank you for joining. We had an excellent discussion Tuesday on the first Outbreak Control Strategy session. And today, we will have the second session, and that will be based on a hospital-based scenario. You're all familiar with the outbreak, the breakout room rules now. Every breakout room will have 1 to 2 minutes introduction, 5 to 15 minutes discussion, a wrap-up session, transition, and then the discussion in the common forum. And each breakout room will have a leader, a timekeeper, moderator, and a scribe to facilitate the process. Now, this is the interesting scenario. Tracing the invisible enemy. In August 2022, at a renowned oncology center, the first patient with Burkholderia cepacia complex bacteremia, that is a child with chronic granular matter disease, is transferred from another hospital. And then within a few days, another pediatric case soon emerges. Both patients have developed bacteremia while inpatient in the pediatric ward. The hospital steps up infection control measures under the presumption of cross-contamination. As we know, Burkholderia cepacia complex is a group of environmental bacteria. The complex has more than 20 species. It's a gram-negative bacillus. It is a well-known cause of device-associated infections like VAP, CLA-BSI, and infections in immunosuppressed patients. It is known to colonize the respiratory tract of patients with cystic fibrosis, bronchiectasis, chronic granular matter disease, and other immunocompromised patients. It is a well-known cause of hospital outbreak. Is this an outbreak? That's the first question. Is this an outbreak? As per the CDC definition, a hospital infection outbreak has the occurrence of more cases of an infection than would normally be expected within a healthcare facility during a specific time period. And controlling an outbreak, the basic steps: identification of outbreak, investigation of outbreak, the intervention, communication, surveillance, prevention, and evaluation. The basic steps of all hospital or any other outbreak process. This particular case, 2 patients in the pediatric ward with Burkholderia cepacia bacteremia. One patient had Burkholderia cepacia bacteremia while in another hospital and then transferred. That patient again had Burkholderia cepacia bacteremia. Within 3 days, another pediatric patient. The next bed had Burkholderia cepacia bacteremia. Who should attend the immediate emergency meeting? How should the hospital staff work to ascertain the cause of these infections? What immediate protocols must be established to contain the potential spread? Now, we need to go for the breakout rooms.
To have a case definition, correct? So which cases, if we have a case definition, will be much more clearer. So yes ma'am, go ahead, please go ahead.
Yes ma'am, this case definition says that as the
okay, then basically water. So water, that is a core area. So now we need to identify from where all this water, what are all the sources of water in that unit, right?
Yes, sir.
So what all could be there?
the sink.
Okay.
Then you have the what water is big used to clean.
Okay.
Breaking, couldn't hear properly.
That's what I
Oh,
felt.
now you're audible?
Now,
Yeah.
yeah, it's better. It's better now.
Okay, okay. So I will add the point once more. Okay, because the diagnosis is very challenging and tricky in this opportunistic pathogens like Burkholderia, cepacia bacteria, because the symptoms of bacteremia is same as that of the symptoms that are showing after their chemo treatment. So it is very tricky and very challenging for the physicians to identify.
Analysis part.
Yeah, so we can involve a pharmacist also in the meeting.
Yeah.
Immediate meeting. Okay. And the third question, what immediate protocol to control the outbreak, isn't it? That was the third question.
Yes.
So in that case, all the primarily hand hygiene and then all the contact precaution.
And
Whether
one more point I want to just express. The bacteremia we had discussed in terms of the products used, environment, healthcare worker and all. And though both the patients are pediatric with a suppressed immunity, we also have to confirm a microbiological diagnosis whether any other particular anatomical system is also having infection, especially pulmonary or any other predisposing risk factor which are done predisposed exclusively to bacteremia.
yeah, that is what, yeah, respiratory system involvement is there. Okay.
And what is the duration between the first case and the second case has to be analyzed. And whether any similar products, the line of management, or whether it is similar or whether any difference in the management protocol, that also has to be looked out, provided if there is sharing of the fluids or therapeutic agents. But the question is how to control the outbreak so that we don't land up with case 3.
Five more minutes or 2 more minutes?
Really?
Really,
Okay.
sir?
Okay, fine. After this, few more slides, you'll get a better idea.
Yeah, I know.
Then I'll give you more time. This is very interesting cases, you know. Good. I know you'll get all of you need days and days to discuss this case. I know that. It's very interesting. Even for me today, after dealing this case 2 years ago, still, you know, this is one case I had to call almost every infection control consultant in the country for second opinion. Recommendation and action, team 4. Let's start with team 4 today. That was a suggestion by Dr. Divya. You know, we should start sometimes from 1 to 4, sometimes 4 to 1, and sometimes in a random order. 4, team 4.
Yes, sir. Who's team 4 actually, sir? I missed that part when we were doing team allotment, sir.
Really? Let me. Okay. Let me and read out. Team 4 will be Pallavi Deshpande, A11, Shanmuga Vadivu, Uma Maheshwari, Dr. Pradeep Patil.
Okay, sir.
So Dr. Uma has taken a lead for this case.
Sure, Uma ma'am. Team 4 hasn't joined back.
Uma ma'am, you're still muted.
Now am I audible?
Yes.
Yeah, fine. Sorry. And Actually, the initial case information provided me, I wanted some more case details, whether the case one when was transferred from the outside hospital to this oncology center already came with bacteremia or not, and what was the previous medical records. That information is required, and what was the duration between the first patient and the second patient. So that two information is still more needed for further exploration of the case. And pertaining to question number 1, the emergency meeting should form the following committee members: the consultant pediatrician and the oncologist who's treating the case, and the chair of the hospital infection control, the medical superintendent of the oncology center, the microbiologist, and other treating consultants who give opinions, who are attending to this patient for other systemic involvement, and the clinical pharmacist also. And provided if we have the entire details of the treatment which was taken in the outside hospital, that would be fine. And also we can involve the former treating consultant of the outside hospital from where the child was referred. So these members will form the meeting core committee members. And how should we, and also the healthcare workers and the staff nurse, the dedicated staff nurse who had been attending to the patient 1 and the patient 2, whether both of the staff nurse were the same or different staff nurse, and whether there had been any other rotation duty among the staff, and the nursing superintendent can also be incorporated in the team to keep a check and track of the nursing care activities. And detection of source should be identified. The products used for the treatment, the IV line, the catheter, and the fluids, be it IV fluids or the antibiotic, whether it was a single dose or a multi-dose vial, the stock solution used to prepare, and the reconstituting fluids, the shelf life of the fluid, expiry, and whether there is a checklist which was adopted prior to administration into the patient 1 and patient 2, and also the lot of that particular agents. Pharmacy check can also be used, and the clinical pharmacist can be involved for this component of activity, and whether the bundle care all were adopted. And case 1 versus case 2, these two information is required: the duration between the onset of case 2 and the case 1, and how to go about with it. We have to have a check verification of the infection control protocols, whether there was any deviation or whether there was any negligence, and hand hygiene and contact precautions has to be strengthened. And since it is a case of bacteremia, we also have to identify whether any other systemic involvement is there, whether respiratory system or any other anatomical site had predisposed to bacteremia, and whether there is any chances of transmission from case 1 to case 2 should also be evaluated. This is my input along with the team discussion.
Okay, I will clarify, ma'am. This patient came from another hospital. That patient hospital had Burkholderia, cepacia, bacteremia, cleared. And when the patient came to the hospital, patient was fine, and then developed fever, bacteremia. The patient was fine when the patient came. There was no active infection when the patient reached our hospital, this hospital. The duration gap between the patient 1 and patient 2, 3 days. The same nurse was taking care of both patients. Next bed, same nurse was taking care, at least in some of the duties, same nurse was taking care. Next bed, no other features, only pure bacteremia. Both patients pure bacteremia. Both patients are different. One is AML, other one is ALL, different chemotherapy regimens. We could not find any common chemotherapy. Now, all this, as mentioned, all these are important points. All these are steps off. But these are 2 patients, same antibiogram. Yes, I'm clarifying, same antibiogram, both Burkholderia. Next bed, same nurse. Should be looking for all these components for 2 patients in the hospital. Next bed, same nurse, same antibiogram. Should I do all the checklist, stock solution culture, all the chemo? There are dozens of drugs, dozens of diluents for 2 patients. Next bed, same antibiogram. Okay, I will come to the next group, the group 3. Let's leave your opinion. But thanks, ma'am. Wonderful suggestions from your team. Group 3. Ashok Kitty, Dr. Arya, Kyle Vidiraja, Madhuri Lakshminarayan.
Dr. Kyle, sir, she's the leader of the group, sir. She's
Yes, ma'am.
jotted down all the suggestions.
Yeah, good evening, everyone. So according to the case, according to our discussion with our team members, so the initially like we have to confirm it's an outbreak. So we'll go through the isolation of Burkholderia capacia in that particular organization last 6 months to 1 year, like how many got isolated, and if it is going to be less than 1, then this is to be confirmed as an outbreak. And second thing is like we have to form a immediate multidisciplinary team to find out the root cause of the outbreak. And among the team, the members are mainly like infection control team, then a clinical microbiologist, and hospital administrator, and the ward staff nurse or the supervisor in charge, or the nursing superintendent plus the ward staff nurses, then the treating consultant and intensivist and ID specialist all should be involved in the multidisciplinary team. So they have to find out the root cause of the organism mainly. So as now sir has clarified, like the patient is cleared of the infection and again develop symptoms. So we have to ideally see the duration of antibiotic given to the child. So Burkholderia capacia, if it's going to be the cause of bacteremia, it minimum needs 3 weeks of treatment. Whether that is, we have to find out the reason for the repeated second child, as it's rightly pointed out, patient is placed nearby next to the infected child. So it's ideally something shared is the root, is the cause. So the first thing to be made is like the baby is isolated with the organism should be cohorted. So the other baby should be separated and the ward should be completely cleaned. And we have to look for the source commonalities. As it is rightly pointed out, it's infection control nurse, whether there is a breach in infection control practices, whether the same gloves is used, whether the hand hygiene between patients is not taken, that moment is missed. We have to take care and we have to rectify it immediately. So then we have to look into the source of the organism. Source can be like shared items, hand sanitizer, or a soap solution, or a gauze, or whatever it is, or a same tray is being carried from the baby 1 to baby 2. So those things have to be looked at. So right from that, as it's clearly pointed out, it is not the same antibiotic or same medicine shared between the 2 children. So the stock solution is it's not, it should be not, it cannot be considered as a primary reason. So we have to look into the other possible contamination surfaces. Like the staff nurse, even staff nurse hands ideally should be this thing, being a common organism in the environment. So that is regarding the finding out the source. So the complete thorough checkup should be made, and this baby should be cohorted, and the new protocols with clear-cut hand hygiene and clear-cut contact precautions have to be initiated to prevent new infection. So that is regarding the second part. And coming to the third part, the third part is that new protocol to be followed. So anything else I missed?
Yeah, I will clarify. Immediately after identification of Burkholderia capacia in the first patient, that patient was isolated in a single room. After 3 days only, the second patient came, and both became positive. Both patients were cohorted in one room because the same antibiogram.
So the same antibiogram is more towards the outbreak information.
Yeah. So it is an outbreak. The center did not have any Burkholderia over the last 3-4 months. And that center did not have a Burkholderia outbreak for a long time, except sporadic Burkholderia, over the last 2 years. But there was no outbreak of a Burkholderia cepacia in the center. It is an outbreak. It's by definition, it's an outbreak because there's occurrence of cases that is more than the existing case or the already existing cases. That center did not have Burkholderia for a long time. Suddenly 2 cases, next bed appeared. It's an outbreak. Team 2. Team 2, help us.
Good evening, sir.
Dr.
Good evening, sir.
Jashveer, help
Dr.
us.
Jagir. Yes, sir. Sir, listening to the third and the fourth group, I have very little to say now. Regarding the emergency meeting, like as discussed in our group, it's like the infection control team. It's the infection control officer, infection nurse, then MS, and the ward in charge. And also the administration maybe will have. Regarding the source, all the water sources, as already discussed, the sink, water,
We
then
lost you, Jashbir. Yes, good.
humidifiers, then the saline salt used, and also if the patient had any kind of line which were inserted with USG guided, the USG gels, maybe they were contaminated. We need to look for those. Then we need to more focus on the water sources actually, because as we know that Burkholderia cepacia is something which we get from water. And regarding the protocol, as they were already isolated, all the infection control protocols need to be in place, mostly the health hygiene. And can we go for some kind of like,
Jashbir, we didn't get you.
Yes, sir.
Last sentence you want to go for?
Some sort of surveillance to check for like whether any healthcare worker is carrying them.
Okay. Team 1, thank you, Jashbir. Team 1.
Hi, Alia will be the
Yes, Alia.
leader. She'll discuss the case.
So our case definition will be any patients with Burkholderia positive in pediatric ward within 2 to 3 days with the same antibiogram. That will be our case definition. And the stakeholders will be pediatric doctors, infection control doctors, hospital management, MD of the hospital, nursing head, quality, microbiologist, clinical pharmacist, patient, and patient attenders.
Okay, your team want to add patient and patient attender. Yes, they are the stakeholders. They are the most important stakeholders. Yes, we should never miss the patient and attenders.
We'll confirm it's an outbreak because, as you said, the institution did not have prior Burkholderia since couple of years, and the patients with culture positivity had same angiogram. So that's how we confirm it's an outbreak. So our next step will be isolating the patients, sending cultures, then talking to the attenders, find out the root cause, then find out total number of patients, and find out what's the common link between the patients, then treat the bacteremia. Did I miss anything?
Madhuri should say.
I think.
And Divya. Divya. Yeah.
We've more than covered so many points.
Yes,
Divya ma'am, Madhuri and Sharik and all faculty and the participants, all of us, we have covered the whole Burkholderia outbreak investigation. So many steps. It will take weeks and weeks to carry out all these cultures, all these steps, tracking down all the drugs, all the diluents, all the materials. A hand should be cultured, environment should be cultured. Yes, cohorting is easy. So now, what is all the 4 teams' main hypothesis about the source? Is it cross-contamination? What is the most likely hypothesis?
Yes, cross-contamination.
Let's be very practical. I know it's a discussion, but in a real world scenario, in our hospital, 2 patients, neighboring beds, within 3 days, same antibiogram, same ward, same bed, next bed, same nurse. What should be our most practically in what we do in our real life scenario? What will be our hypothesis?
Cross-contamination only, sir.
Cross-contamination from the healthcare workers, maybe.
Yeah, somebody, a doctor, nurse, or material or something. Yeah. Some cross-contamination between two to patients. So of course, we cohort them, step up infection control, correct staff deficiency, cleaning, everything done. Everything done. Done.
Sir, I'm sorry,
Whatever.
sir, if I may add or just ask something. Sir,
Yeah.
I don't know, in a real life scenario like this, or if we have two cases of Burkholderia cepacia and ICU, sir, to my experience, whatever experience I've had till now, sir, administrators, quality people, as in, yeah, it usually stays restricted to an infection control team. So I'm not sure. I mean, I could have a different viewpoint on this, but
Completely agree. Yeah, completely. The last case also, you raised the same point, and it's a very valid point. In the real life, for two patients, we don't involve the administration. We don't involve the administration for two patients. Okay, we can involve the housekeeping, the primary consultant, housekeeping. What we, in my real life, they do is two patients. We do, of course, an outbreak meeting, but a small group meeting.
Small group.
We don't involve the CEO. We don't involve. We may intimate the medical superintendent.
Absolutely.
We intimate, but yeah, CEO is not usually informed. The nurse infection control team, of course, the primary team, of course, ICU or pediatric team, the oncologist, yes. Housekeeping, of course, yes. Microbiologist, of course, yes. But beyond that, the big team, lots of investigation in real life, in my experience, is not feasible. Let's think about all the possibilities. But should we do everything in real life, or will we do in real life? In my experience, no. Limited teams, basic steps. My hypothesis is cross-contamination. And everything is done. Isolation, hand hygiene, environmental cultures, of course, done. Now, the story progresses.
May I add? Sir, may I add one point?
Yes, Siri.
Sir, normally in such scenarios, what the first question is, what was the duration? I mean, like when this patient was admitted and when the bacteremia happened? Was it after 48 hours or less than 48 hours?
Okay, now these two patients both were after 48 hours of admission. I'll give one more point. Both had PICC lines. These are chemo patients. So chemopod. Both had chemopod. The one patient's chemopod was earlier inserted in another hospital, taken out for Burkholderia in that hospital. Another clearance only, they reinserted a new chemopod. And other patients had a chemopod inserted a month ago. But both were admitted for more than 48 hours. These two patients had the bacteremia after 48 hours.
Okay. So why I asked that, if it is less than 48 hours time, you get a bacteremia, it is a clue that we have a direct contamination into the blood.
Excellent point. Dr. Sharik has made an excellent point here. We should never forget that. If the duration is the bacteremia, that blood culture was drawn within 48 hours of admission, it cannot be a cross-contamination between one patient to another patient. It has to be a directly administration into the line or somewhere. Am I right, Dr. Sharik?
Yeah, sir. That's what I said, because I had a similar case scenario where one neurosurgery patient got admitted and got a aciniton next day. It was actually the 100 ml normal saline, which was contaminated. So less than 48 hours, it's straight into the bloodstream. That's how I divide.
Wonderful, wonderful point. Wonderful point. Yes. In September, 2 adult patients presented with cepacia bacteremia. But the antibiogram was very similar to pediatric patients. And that's different ward. Different floor of the hospital, not even the same floor. All 4 patients had undergone chemotherapy. Then, of course, then the hospital started looking for a common source. You can explain the cross-contamination between 2 pediatric patients. These are different ward patients. And the team looked for a common source. Again, cross-contamination. I found all the 4 had chemo in the daycare chemo earlier. Daycare chemo, all the 4. So another potential source of cross-contamination in the daycare was made. Environmental samples from the daycare, everything from the daycare were done. Now, come on. Let's repeat the same question. Questions remain the same. The problem is slowly getting out of the hand. 4 patients, 2 in pediatric, 2 adults. The only common source for cross-contamination we found out was in the daycare. All the 4 had chemo in the daycare recently. Now, we really need the breakout room here. The scene is getting hot. let's discuss.
Treating the adult patients, and their oncology is there. And the case definition definitely changes because earlier it was only pediatric patient. Now the location is also changed.
Absolutely.
We have a common link, and the age group also has changed. Case definition should
Absolutely. So case definition is not just the pediatric individuals, it will be involving all the other patients from this. And what is the common link as we had discussed?
For the blood cultures, because this is happening, and any history of fever, like you can suspected history of fever also, you can send the blood sample to trace at least the Burkholderia happening in any other places also. Any just history of fever, one day also better to send the blood culture, like that we can make one
Exactly.
circular to
Would
them.
you like to do environmental sampling at this point of time now? Is it warranted? What in your opinion? Now is environmental sampling?
Exactly. We would like to do the daycare area. Yeah, exactly. The daycare area should be completely sampled.
Okay.
So the water source of daycare area
yes,
should be also.
And sir also pointed this is happening in different floors. One is pediatric, another in adult now. So we have to think broader, like the other sources, like common. What is any common port, like water pipes or any carrying of items to the trolley from that place to this place. So like we have to trace the broader area, because things they are in different floors. Pediatric in different floor, adults in different floor. No? Any common source to whole hospital is there, that also you have to trace it.
Fair enough.
So, or any other representatives from the access control to discuss about controlling access to the affected areas?
From where? Sorry, I couldn't get you, Dr. Arya.
So, any representatives from the access control or the hospital security and other access control team of this ICU to discuss about the controlling access to the affected areas?
You mean restricted access of visitors to the
limited the access to the
Yes. Sure. Means you're basically trying to step up the infection control protocols and making it more stricter by restricting the number of visitors who coming to the area. Okay, that is one thing. Then
Any centralized, if it is centralized AC with hospital, within the oncology unit, no? Like any breach in the HEPA filter integrity or anything is affected in this case. But it have affected a whole other cases also. But
yes, it would have affected more cases. If that was a source, it could have affected the other cases also.
Another thing, who is the nursing staff attended on all the cases? Only one nursing staff is involved or not? That you have to check, no?
Yes. As per sir, one nursing staff had attended both the pediatric patients, but we are not sure. We are not aware who were the nursing who actually attended to the adult patients as well.
But you have to check from the register, no? We can easily trace out the.
Yeah, we should try out the common. We should try and find out who were the common healthcare personnel who attended to all these patients. So basically, we're trying to find some common link here that could have possibly caused a cross contamination.
Yes.
Okay. Any more inputs, sir? Anything else you'd like to? Any other protocol you would like to step up? What would you like to collect in environmental sampling apart from swabs from the aqueous sources like water taps and faucets, and what else do you think in the
air sampling also can do, no?
Okay, air sampling we can do, but I don't know how valuable air sampling would be here, considering Burkholderia cepacia is not really.
I would like to do the chemo port.
Chemo port. Okay, one was chemo port.
Swab from the chemo port of all the thing. Then IV line, IV tubings.
Saline.
Yeah, saline which is used for mixing the solutions. Yeah,
absolutely.
Like in case saline or distilled water, whether it is be used for mixing the chemotherapy agent that can be
yes.
used.
What else?
And the equipment
Then the routine thing, of course, all water sources should be looked into, even the hand wash, soap solution, hand sanitizer again. Um,
Yes. Hand
Of course, the
sanitizer.
staff nurses involved in basically.
Yeah, these non-fermenters, they are known to even thrive in the disinfectant solution. So absolutely right. We'll
Yes,
collect the disinfectants also and hand rubs also from the area. Okay, what else? Now we have a huge list of what we are going to sample from these areas. So at this point of time, such extensive environmental sampling is warranted also. Now it is actually spreading and now it is actually becoming a cause of concern gradually. So
Yes.
now an extensive environmental sampling is warranted. So what else? Any more inputs?
Welcome back. Am I audible?
Yes, sir.
So,
Let's hear from team 3.
Yes, Pierre.
And one
We
humble
are from team 2.
suggestion, if one team has made a few suggestions, the other team better not repeat the same suggestions and provide the suggestions which is already not discussed. Team 3. I think Dr.
team
Kayal.
3 is, yeah, Dr. Kayal or Dr. Ashok, so anybody can kind of take the lead and tell. Dr. Arya, Dr. Lakshmi. Dr. Kayal, where did she go?
Yeah, I can. I thought someone will be cooking. So, as with the broader group, since it has happened in the daycare surgery, we would like to include the oncology department head. So, the oncology should be involved in the stakeholder as a new stakeholder. And since the case has spread from 2 pediatrics to 2 adults, there's a note at least should be sent to the head of the organization. This is being going on, like CEO. Even if the CEO is not a part of the main stakeholder, the information should be passed on. So then the daycare, other than nursing superintendent and staff nurses, the daycare in charge also should be involved in it. So these are the new stakeholders who can be involved. So coming to the next part, like we have to find out the source of the organism. So here, being in a chemotherapy unit, the commonalities, basically the saline solution or distilled water used for preparing the solution have to be tested. So then the chemo port of the patients, the IV tubings, lines, then of course, being a cepacia can grow in disinfectant nicely, the hand sanitizer, soap solution, and the water source have to be thorough environmental sampling should be done in the daycare unit where the all the 4 patients have been taking treatment. So that is for the second part of the question. So the third part of the question is strict infection control practices to be implemented. Single-use items to be used. There shouldn't be any reuse items. And of course, as our team members discussed, equipment sterilization have to be made more stringent. So maybe like sterilization monitors or something to be checked. Of course, it is routinely checked in all the hospitals. Any breach is there to be addressed. Other than that, any other points I missed, my team members can add on.
And also,
Okay, yeah.
and special protocols for the patient care areas. Am I audible?
Who is talking?
Yeah, your voice was breaking, Dr. Arya. Can you please repeat what you were just saying?
We can also implement enhanced cleaning and disinfection protocols for the patient care areas, equipment, and high-touch surface using effective disinfectants.
We have to send a strict this thing to microbiology department. So any new case or any Burkholderia cepacia organism getting reported in any part of the hospital should be intimated immediately so that immediate action can be taken to cohort the patients. The spread can be anticipated. So that should be given extra weightage. So any other then history of fever, maybe like 1 or 2 days also cases also have to be intimated so that we can try to find out the cases as earlier.
Team 2.
Yes, sir.
Dr. Jashbir and team?
Yes, everything is
Voice is breaking, Jashbir.
discussed only. Just what we discuss actually things between the patients, the water bodies, all water sources, and also someone mentioned that we have to also ask for the parenteral nutrition maybe.
Okay, look into the parenteral nutrition. Yeah, none of these patients were on parenteral nutrition. Good point.
Okay, sir. And then, sir, other protocols already discussed is strengthening the IC practices and disinfection policies, what they are using actually. That has to be more.
Yeah. Now, before progressing the two teams, in a real life scenario, now it's easy for us to enumerate all steps. But to look into every step, starting from sterilization to hand hygiene, to environment, to water, to cross-contamination, is a laborious process, enormous manpower, enormous number of cultures. Starting from the two cases to every step, it's not possible to look into everything for every two patients having maybe two MRS or two Acinetobacter. We need to be very practical in our approach. It's easy for us to list it. It's really possible to carry out all steps of everything that needs a lot of manpower. It's really practical for any infection control team, even though good manpower. So that's my humble suggestion. Any discuss we discuss, let's be grounded on the real life. When you are the person heading that outbreak in your hospital with all the limitations and the realities of the limit in that hospital, then we can have a better discussion, better training on the real life rather than going through every step. Of course, we need to think every step, but can we act on every step? It's not easy for my team to go and check the sterilization for everyone. We do routinely, but just because there are two Burkholderia there, is it possible to follow all the steps from A to Z, everything again? I just need your feedback. Now, team one.
Yeah. Dr. Alia will enumerate all the points discussed.
Yeah. So at this point, we have two pediatric patients and two adults. So it's high time we involve the management at least now. And the next, I have a question for you, sir. After how many hours did the adult patients culture were positive?
The gap between the first cohort and the second cohort were 2 weeks, and the adult patient, one was not admitted at all. He had this chemo in the daycare. Another patient was admitted, but the bacteremia happened after 3 days of admission. The first blood culture was taken after 3 days. The patient developed on that day, day 3, and the blood culture was taken. One patient was not admitted in the adult unit, one not admitted, just had chemo in the daycare. Even though we called it as a ward, two patients, the patient was not really admitted to the ward when we had an inquiry.
Okay, at this point, we can expand the stakeholders. We can involve the management. There should be a collaboration between microbiologist, oncologist, infectious disease, nursing superintendent, housekeeping head, like that. Then the measures involves, first we have to isolate all the patients and assign individual nurses for each patient. Then we are still suspecting cross-contamination. So we have to find out the common link, strengthen our infection control measures, find out where the infection control were breached and what happened. And to find out the root cause, we should first send out the samples starting from the water sources around the oncology centers and other common links, and any medicines or anything that is common between the patients should be sent for sampling. And surveillance, we have to take in consider all the patients that were in the daycare at that day. So the stakeholders also involves the doctors and nurses and housekeeping staff who worked on that day. So the next question is like whether we should find out all the patients who are in the daycare and send their cultures, or should we narrow our sample to patients with chemoport, etc. like that.
Team 1, now again, my humble suggestion, let's discuss the most important steps. We all know the outbreak control investigation. We all know each and every step. We all know each and every source. But how practical is to do everything for small clusters? In my experience, it's not feasible to look into everything. It's not feasible to look into all cultures. It's not literally feasible in real life. That's my experience. It may differ in various setups. Team 1, team 4, isn't it? Team 4. Dr. Uma, who else is there in team 4?
Dr. Uma, you're muted.
Am I audible now?
Yes, ma'am.
Actually, there had been 2 pediatric cases in the month of August and 2 adult cases in the month of September. As per your information, 1 adult patient was not admitted. So the main issue all started with the daycare. So I would analyze the staff who had been posted to the daycare unit who is involved in the patient care and the administration of drugs. So there could be an intervention whether the staff could be rotated if it could give a quality improvement if we change the staff, number 1. And number 2, the nurse to patient ratio who is administering the drugs in the daycare unit. That could also be an intervention part. And apart from that, whether the products used for adult patients as well as pediatric patients or the products from the same supply or from different supply, that also could be verified. Audit could be done, and a random observation of practices of administration could be done so that if any error or deviation in the protocol could be identified on observation. And awareness should be created among a small group discussion of all healthcare workers catering to both adult patients and pediatric patients. Could be all the intervention measures which we could try it as a pilot for a week or so that we do not land up with any other new cases.
What will be the most important, ma'am? We have got at least for the discussion, we have a shortage of manpower. There is 1 infection control nurse and no infection control, 1 infection control doctor. We have a limitation of doing everything ourselves. Yes, we are involving others, but we do have the manpower. We have got a shortage of time, and in real life, in various hospitals, everything is possible in a big hospital. Lot of manpower, 2 doctors, 5 nurses, a lot of clinical pharmacists, so many managers to do all these things. No, it doesn't happen in maybe this hospital, yes, but not in 100-bed another oncology center who has got 50 patients or 20 patients and lack of manpower, no infection control doctor themselves, just a nurse. So we need to look into all the scenarios in our country and not just the high-tech center where everything is available, so many manpower, and the management is going to do whatever you want. No manager will agree to all the cultures, hundreds of cultures. If you do all this culture for 4 patients, there are hundreds of samples to be sent, dozens and dozens of drugs, dozens and dozens of environmental cultures. Manpower should be stepped up everything. Auditing itself will need so many people to audit all these things again. Is it possible in the real life? Yes, all this we know, the discussion points, but all of us, how can we do this? We are talking about the real life scenario, but there are CEOs in every hospital, managers in every hospital, funding deficiency, manpower deficiency. What are the, and at the same time, we are the infection control in charge. We need to control the outbreak. So let's think about the most common, most important thing, and the least effective cost, in the most cost-effective way, least manpower, the better outcome, the most important things that we'll carry out in the real life. This is real life. Our discussions are real life. It's a strategy course. We all know all the steps, but that's not going to happen in any center anywhere in the world. A to Z will not be done. We can all discuss, yes, it's possible, we need to do. But, especially in our country, we're talking about the big tertiary care hospitals to small oncology centers. Sharik?
Sir, how I approach here is that I will actually look into the common factors, the whole common factors. We will get into the case sheets and look for what are all the common factors. And my focus will be obviously on the common factors because it's not any location specific. This issue is not a location specific issue because it's been happening in the different parts of the same hospital, right, sir?
Yeah.
So first thing, identify the common factors and then focus on the common factors. Like drugs, IV fluids, whatever, hand rub used, all those things. So identify the common factor is the key point which I feel in such case scenario because it's not a location based.
Yeah, there are two locations, but they all received chemo in the daycare. But still, so, as you all know, there are two hypotheses here. One is again cross-contamination in the daycare or something else. Something else is contaminated rather than between the patients, something common. Could it be drug? Could it be fluids? Could it be some chemotherapy drugs? But the list is too huge. If we all know, if you look at the drug chart of a chemotherapy patients, how many drugs will be there? Starting from paracetamol and antiemetic, so many chemo drugs. And look at the diluents. Look at the Heplock. Look at the materials used. There are dozens and dozens of them. And even for 4 patients, yes, we need to screen out. In fact, let's discuss that. What the team did. This is what the team did. Now day 30. No, see, all we discussed, not everything was done. The infection control was stepped up, all in a possible way. Staffing deficiency corrected, multiple environment. I won't say everything was sent because that will be dozens and dozens. The common areas and cultures were sent, and then common drugs and fluids were looked into. Samples were sent. Anything commonality, these 2 patients. Samples were sent, but not drug. There will be dozens and dozens of drugs and fluids to culture if you culture everything. That could not be possible because that's not financially viable. And so, but still, common drugs were looked into. Anything that's common fluids, common drugs were all sent, waiting for the result. Day 30, intensifying measures and discovering clues. As October continues, cases multiply, spanning both pediatric and adult. Both. All affected patients recently received chemotherapy. All affected patients received recently chemotherapy. Either in daycare or IP chemo unit. There are 2 chemo mixing, 2 units. The daycare, earlier commonality forward daycare, but now the patients who received chemo, which is mixed in the IP chemo mixing area, are also affected. And symptomatic presentation within 48 hours. Now, most patients has at least a good number of cluster symptoms within 48 hours of admission or earlier chemotherapy. Some of them were chemotherapy, and later admitted with fever. Some of them were admitted in the hospital, developed fever, but a good number of them developed symptoms within 48 hours of chemo, either in the daycare or IP. The hospital intensified its focus on chemo mixing areas in IP and daycare. Almost all patients had central line or chemo port. All onco patients, and the center had non-onco patients also. Center has an orthopedic area and dialysis area. So there are non-onco patients, neurosurgical area, non-onco patients. None of them had infection. Only onco patients. All of them had chemo. All of them had a line. And many of them had symptoms within 48 hours of a chemo. The plot is thickening. We need a breakout room now. cases are multiplying in the hospital. We have no clue what's happening. Culture reports are pending. We need help. So far, all environmental samples are negative. All fluid samples are sent, all whatever sent, negative. Drug samples are, we look for common drugs. Drug samples are negative. Environmental samples are negative, except the patient number is keeping on piling up. A real trouble. Look at the real life scenario. Burkholderia is appearing in the blood. No idea. Everything is coming negative except the blood. Breakout rooms. We need your urgent help now. 5 minutes for discussion. Or 7 minutes for discussion. 7 minutes for discussion. Let's start now. I'm very eagerly waiting for your support here. I'm the infection control consultant of the hospital. I'm in serious trouble. Sleepless nights, friends. And any recommendation that you give me should be practical, cost-effective, least manpower. We discuss. I know you are going to give me a lot of steps now. Yes, I'm in trouble. My CEO, my management, my everybody understand there's a real trouble brewing up. Most of the recommendation you are going to give now, hospital management CEO will agree to do it. But let me remind you, whatever recommendation you are going to give now or given me, you gave me the same recommendation on the day one with 2 patients, next beds, starting with step 1, step 2, all environmental cultures, all common drugs, everything. Is it feasible? No hospital anywhere in the world, John Hopkins, UK NHS, the best hospital in India, no management, no microbiology lab will have the resources, manpower to carry out step A to Z. As an infection control consultant, that's one thing. That is the purpose of, that's why I am keeping on repeating. That's why I took this case. We should be very careful while making the recommendations in the real life. If you make too many recommendations, impractical, you are not a strategic infection control. When I say you, we are not strategic infection control consultant. If you are making unrealistic recommendations, that means we are not understanding the perspective, not only the management, but of the institution. Our responsibility as infection control consultant is not just the knowledge of it, but how we do it in the most. We are managers, we are administrators, we are strategists. I'll call myself not an infection control consultant, but infection control strategist, because I do have the basic theory. All of us have the theory. It's easy. 5 minutes, do ChatGPT. That's what I do. I'll get all the points in the world. If I go to my hospital administration with that ChatGPT recommendation, I lose my job. I will lose my job. Any junior infection control consultant joining any hospital in the country or anywhere in the world with go to 100 recommendations, next day, get that letter. There will be another consultant on board. And if I am the CEO, I'm going to do that. That's the purpose of this course. We all know the points. It's very easy. But which one to select, which one to recommend? I want to stress that point again and again. We have to be in the real life. Now, whatever recommendations you give me, I'm the CEO here. I will most likely listen, as long as you're not going to sell me half of the hospital, do whatever test you want or whatever manpower you want. But I am very, very understanding now. Now I need my infection control consultants' help. Now team 2, please give me your valuable. My ears are very open. My eyes are open. I need you. You are a precious person for the hospital today. Just be here.
Sir, whatever we have discussed in the group, maybe like our microbiology department is not doing something which for maybe we can outsource this. We have discussed. Then We need to
Which
check.
hospital you are, Jashbir? You are my consultant, Dr. Jashbir. I'm your CEO. Which lab you want to outsource? Are you having any tie-up with any specific private laboratory that's
No,
not in
actually,
our
we
hospital?
we need to check for the validate the microbiology
No,
methods.
Jashbir, you are also my microbiologist. I trust you. You are the best I got. I appointed you. I wouldn't have appointed you unless I knew you are the best in the country. You know, your lab is good, Jashbir. I spent a lot of money for your NABL. You know how much you spent? You got all the equipments. Didn't I give you multi-top?
Yes, but this situation is so complex. Maybe some other may be able to help.
Oh, you want a second opinion? That I
Yes,
can
sir.
organize. You want QuorumVeda? There is a company called QuorumVeda organization. Please call. I think I know Dr. Ghafoor and his team. You know, Dr. Divya there, Dr. Sharik there, Madhuri there. So many a big team. You want to call them? Wonderful. I'm happy. I got the money for that. Anything else other than just second opinion, just me?
Then what we have discussed, actually, we have to look for the different brands and a batch number of these chemotherapy agents. So we need to take the help of the pharmacy validation.
Yeah.
These 2 points.
Yes. Now, yes, Dr. Jashbir, yes, second opinion, very important. I will get that. We are in trouble. 22 patients by now, Burkholderia bacteremia, chemotherapy patients, chemopod. I could no problem getting second, third, Jashbir. You just give me the name, I'll call them. You call them. You've got the freedom to call anybody anywhere in the world. I just want my hospital to run.
Yes.
Team, next
Thank you,
team, next team.
Yeah,
Team
Dr.
4. Yeah, which team is that? Who
So
started?
team
Divya.
1, sir.
Team 1, yes.
So Dr. Prerna had some interesting insights based on her personal a couple of things also. So I thought that she should share it so that, you know, we can have this thing also.
Wonderful. If Dr. Prerna give me something interesting, I'll give her a salary raise this month. I won't wait for the next month.
So something similar happened in our setup. We had not similar, we had a Ralstonia outbreak in the oncology ward. We cultured everything from the chemo daycare, from the mixing units, all the fluids. The only thing we could not culture was the chemo drugs because we were told that we can't open a fresh vial and who will pay for it. So the drugs we cannot give you, and the used bottles are the open bottles are discarded right away. So we cultured everything. But the only thing that helped was changing the disinfectant wipes which were used on the patients. So we had a new brand in the hospital. So once we changed the wipes and issued the older brand, the Ralstonia cases came down on its own. So sir, here what I feel since we mentioned that the symptoms were developed within 48 hours. So it maybe means that there's a direct link with the chemo port that are being something which is entering through the chemo port. So things which come in contact, maybe the hand rubs or the disinfectant wipes that are used, or maybe the gloves are contaminated. Surveillance of the chemotherapy mixing areas also. And sir, so maybe we can try changing the samples of the wipes or drugs or any common drugs which are administered in all these 22 patients. Or if there's any drug reuse policy, we can.
Dr. Prerna, I just want to give you some information. Yes, I will send you. I'll change you. You can just tell me a list. I'll change you whatever you want. And it's done already. My clinical pharmacy team, I'm the CEO, my clinical pharmacy team came and told me, you know, this infection consultant is giving me too much of work. So I called my clinical pharmacy team. I did some secret information from them. And they told there are almost like, you know, more than 24 common drugs, including this, if you look at the solutions and all. And my infection control consultant want to culture all of them. And he wants or she wants, you know, 10 samples of each one of them. So many bottles of each saline batch. And when I counted, there are some 200 cultures. But I'm willing to send. I'm in trouble. Sending.
We can the drug reuse policy, if same vial has been used in more than 2 patients, like if there's some policy in that, at least that drugs we can consider.
My infection control team and did some secret work. There was few in one of the refrigerators, you know, some reuse, especially the kids, you know, they need a drop of them. And these big bottles, you know, very expensive. 4 lakh drugs, some chemo drugs. So we are perfectly happy the reuse, the storing in the refrigerators. We looked into, we cultured chemopod. You know, initially the microbiologists, you know, telling it's all chemotherapy drug. How can you send it for culture? We'll be exposed. But still we found a way, Googled and found a way it can be done, and we did it. We did send those open vials for culture. Culture results pending, waiting. Wonderful recommendation. Done. Anything else? I got all my years, I'm in trouble. My hospital is in trouble. I'm depending on your brain.
Sir, so we can maybe try the rotation of the nursing staff that has been appointed in the chemo daycare. Maybe a different batch, rotation of the entire staff and fresh staff is there.
I got a problem. Chemo nurses needs to be trained. I can't put my ICU nurses and neurosurgery nurses there. But still, we brought our senior nurses, trained them and gave them additional manpower. Done. No solution. The number of cases is increasing. I don't know what to do with my chemo. My infection control consultant is running around, not sleeping, calling this, calling that. Next team. Who is the next team? Next 4. Team 4. Dr. Uma and team. We have only reached halfway through the case. Lot to go.
Sir, I think Dr. Uma is not there. So
Next person. Yeah.
Part of team 4. Actually, we are quite stumped because few of us, like none of us had experience in oncology hospitals. But practically, like you suggested, sir, maybe because you said all environmental fluid and drug cultures are negative. And now many patients all over the hospital.
So far negative. We have sent
Sir,
almost
one
200
doubt,
samples
sir.
right now.
Sir,
Yes,
one
Uma,
doubt. Because all the environmental fluid surveillance cultures pending you were mentioning.
most of them are so far everything negative. Some of them more pending. So far everything is negative.
Actually, Burkholderia, the area where the mixing or preparation of drugs happen, that environmental surface, whether there could be chances of biofilm formation mixes. There again, that is again a breach in the practice, or any common thing is being used.
Yeah, most of the environmental cultures, including chemo mixing, cabinet, all that environment is negative. But I'll tell you something else is coming. I will send again. We are sending everything difficult, breaking open this. If
Sir,
my
the
infection
periodicity
control
of the
consultant.
culture, as you
We are
mentioned,
repeated. This is almost 30 days now, repeated. Everything repeated.
So actually, we had a similar outbreak in our hospital. So I'm attached to a 100-bedded pediatric hospital. Like you said, it's not a very big place and we are in a smaller town. So it was in the NICU and we repeatedly got blood cultures which kept growing Burkholderia cepacia. And most of the patients were not very sick. 1 or 2 had suspected sepsis. So then I went and inspected the NICU. I observed what the nurses were doing. I spoke to the neonatologist, like exactly what happens when the baby enters the NICU. And then what we discussed, we found that as soon as the baby comes, before they collect the blood, a bolus of dextrose is given. So then we checked, there were 2 dextrose bottles and we sampled only those, and one of them grew Burkholderia cepacia. And after that was discarded, the outbreak stopped. So I think something, maybe one of the fluids that is being used in the daycare.
Yeah, we thought of a wonderful suggestion. We cultured almost every fluid. There are 200 now. The samples have grown to 300. Microbiology department is busy culturing from top tank, water tank to the under the carpet. CEO's hands, consultants' hands, oncologists' hands. All oncologists are now closing the eyes and walking. They don't see my team because they are swabbing. And every wall of the hospital, every roof swabbed. Lakhs spent already. New manpower, lakhs, and microbiology department. Microbiology is busy. The whole machines are busy with the Burkholderia culture samples. Next team, all the 4 teams discussed?
Sir, team 3 is still
team 3. Team 3, we need, come on.
Dr. Kayal, ma'am.
Yeah, sir. So most of the points are already discussed, like chemo.
No, before that, Dr. Kayal Raja, neurosurgeons are paid 150 times more than me and you get paid. This is your opportunity to ask for double the payment of neurosurgeon. The CEO will listen to you today. So whatever recommendation you give me, please think double the money of your senior most neurosurgeon you are getting.
Sir, since the patients are getting within 48 hours, Burkholderia capacia is directly infused into their blood. So whatever is going through the blood, through the port is the culprit. So it should be either a chemotherapy drug or the mixing solution or the IV fluids, which is given before or after the administering chemotherapy agent. So that will be the most probable cause. So
Yeah.
we
I'll just
since
clarify. It's a wonderful
as you said,
suggestion.
we have done,
Ma'am,
we have done more than 300 cultures.
I'll
The
just
culprit should be
clarify
one among
something.
this.
Yeah, I just want to clarify. Not all patients have symptoms within 48 hours.
Sir, your
Some
voice
patients have.
is not audible. It's breaking.
Oh, really? Am I audible now?
Yes, sir, you're audible now.
Okay. Now, half of the patients had chemo within chemo within 48 hours, 48 before. Some of them had chemo.
Patient's bloodstream. So
No,
that
some of
should
them
be
had,
given
no, 1 minute. Yeah, definitely yes.
additional weightage, and we have to culture
Given.
everything. No other go.
Given. I want to add something. Rest half did not have chemo. Some of them had chemo several weeks ago. I told there is a cluster, some commonality. Not all of them. Half of them had chemo. Not all of them. At least a good bunch of them had symptom within 48 hours. Some of them had the chemo several weeks ago. But they had some kind of line use 2 days ago. Not all of them had. It is a good pointer. If that would have been all of them had within 48 hours, our life would have been very easy. No. Some of them had chemo weeks ago. Some of them chemo was given a few weeks ago. The one patient chemo was given 2 months ago. 2 months ago, 1 month ago, weeks ago. But there was a cluster within 48 hours symptoms started.
So, but all the patients
I'm talking chemo. I'm talking chemo. All had line. Except one. Except one. So
anything
far,
that
except
comes
one.
in contact with the line.
Except one.
It can
One
be
patient did
a
not have care. Yeah. Alia.
So anything that comes in contact with the line.
Well, yes, exactly. But what do you want? You are the clinical pharmacist. You have got a list of 200 drugs.
So it can be as simple as the flushes we use.
It could be.
Sir, it could be even the alcohol swab, sir, as one of the doctors.
So I think one of the groups mentioned earlier, did we test any of the gels?
Oh, really? Yes. Ultrasound gel, isn't it?
Yes.
Yeah, we'll come to it. It's tested. It's positive, but I'll come to that later. Because, radiologists, at least some of the patients, they use ultrasound gel for put in the line. And it became positive, but I will tell you what happened after that. But it's a good thought. We cultured gel. Report is pending. You will get the report. Now, can I go to the report? Next steps? Fine. Now, this is for you to celebrate. Celebration starts. Majority of the patients in the cluster had recently received chemotherapy in the daycare or IP. Two possible explanations. An internal cross-contamination issue in the daycare or IP, an external contamination, for example, a drug, IV fluid or line. Two hypotheses. We are hitting hard from both sides. Among the environmental sample, B cepacia complex is discovered within the gel of sealed ice pack used to transport mixed chemotherapy drug. Full culture result pending. See, the daycare and IP, chemo mixing units are eminently separate. But sometimes our clinical pharmacists or the hospital mix it in one nice, beautiful, clean ice bag, a box with a nice gel. It's a packed ice pack, ready-made with the plastic boxes with some fluid gel inside. Carry that boxes inside with the chemotherapy. So we had the cross-contamination doubt. So the team broke open that box. It's a sealed, frozen, broke open. That's not what is a jelly kind of material. Sent for culture. Multiple samples. Burkholderia cepacia. That was a day of celebration for the hospital. Gel. Got the source. God, wonderful. Congratulations. Everything done. Immediately. We bought new ice packs. That day, new ice pack. And even ice pack, refrigerator changed. We wanted 3 refrigerators in the hospital changed overnight. Whatever you do is carried out now. It's not like the day 1 with 2. There are 25K patients. Everything will be carried out. New refrigerators overnight. New gel packs. What else you want now? Can we celebrate? Okay, now the next day, what happened? My microbiologist disappointed me. This antibiogram is different from my clinical isolates. Celebration ended, all the bottles open, lid put back. The sad story starts again, hunting starts again. Now, okay, now this is hypothesis. Kept up the infection control measures throughout the hospital, oncology, daycare, everywhere, recruited additional staff, enough number of staff, carried out cultures, drugs, swabs, sinking, whatever you want done. Cultured IV fluid, medication, reconstituted antibiotics, non-reconstituted, refrigerated, everything. There are reports of B complex bacteremia contamination of reconstituted antibiotic preparation stored in the refrigerators. All the samples were cultured, everything negative. Now, this is how we did that. Okay? The patients in the dialysis unit and ICU had long lines. None of them Burkholderia cepacia. None of them. ICU and hemodialysis units did not use heparin flush as part of line care, whereas the chemo daycare IP units, heparin flush. Those patients, onco unit, use heparin flush for the line. ICU doesn't use heparin flush. Dialysis unit use different heparin flush.
Okay.
So we cultured it. All the cultures came back as negative. Still we changed the brand. Everything is negative. Everything is negative. It's not the heparin. None of the oncology patients had an infection with B. Non-oncology patients had a bacteremia. This pattern led us to hypothesize that something exclusively used in oncology might be the source of outbreak. All the affected patients received chemotherapy in the recent past, spanning from weeks to days or several weeks prior to bacteremia. They received chemotherapy either daycare or inpatient area. Inpatient and daycare both have different chemo mixing cabinet, eliminating cross-contamination. Still, ice packs were the common source, found out, ruled out. Day 45, days continue to increase. A previous outbreak in another of the hospital, ultrasound jelly had grown, Burkholderia cepacia had a callback. But when tested, several of the ECG ultrasound jelly bottles had Burkholderia complex. But this time, we did not open the bottle to celebrate because ice pack experience. We waited for one more day for the antibiogram. Again, different antibiogram. Otherwise, we could have got the source. That grew Burkholderia, but it had the same antibiogram of the other hospital's outbreak. During the callback process, some of the ultrasound gels were left over in the cabinet of certain departments. That was the one positive, not all ice pack gel. All others were called back, but few were left in the department. Now, all other environmental samples negative. Friends, we are talking about hundreds of environmental samples from the beginning. Hundreds. All negative except the ice pack and gel is different. 56 patients are Burkholderia cepacia back treated. Now, what should I do? What should the hospital do? The decisive meeting, the infection control consultant called, there are multiple meetings, at least a dozen meetings in that short period, 2.5 months. There are dozen meetings of all the stakeholders, I'm telling, all the stakeholders. Now the decisive meeting from the highest management, because the recommendation that the infection control consultant is going to make is stop the chemotherapy of that hospital, of a top hospital in the country. Stop. That was a recommendation going to be made. So you've got the most important people. The hall is full with the VIPs. And the recommendation the infection control consultant is going to make is, we are enough. Let's stop the chemotherapy. We don't know the source. At last, during that meeting, the infection control suggests the management call a meeting of senior members and hints the possibility. The moment you hint the possibility, every top people on the board. We can't stop chemotherapy of a big onco center. That's not something unthinkable. Hasn't happened. It's happened in the history, but not in the history of the hospital. Now breakout rooms. Can we go for a breakout room or should we discuss? It's 9 o'clock. Should we continue the discussion?
We will continue with the decision.
Yes, continue. We'll continue. If we go for the next week, we'll lose the, the suspense. I'm not going for the breakout room. I'm going for discuss. We already discussed all the possibilities. Without going for the breakout room, do any of you have any suggestions? Without a breakout room? Anybody? The infection control consultant is going to recommend stopping chemotherapy in a big onco center. It's something, shakes the hospital. shakes the management. You are the most important person. The survival of that hospital for the time being depends on you, nobody else. You want crores? And the CEO will give you crores of funding for the investigation. What you want in the world, will be there next day. But you have to do it. You can call anybody you want. You want ideas. Second, third, anything you want in the world is there on your foot. Any suggestions? This is your perfect opportunity to get a Ferrari car if you want.
Sir, we faced a similar scenario in my hospital, of course, 7 years before. Yeah. So what I couldn't find out. Wherever it grew, it was Burkholderia capaciae from blood culture. So finally, I didn't miss the soap solution. I cultured the soap solution which grew Burkholderia capaciae. So I cultured from each ward, the bottles, and from the source housekeeping. Then I traced back. Then I came to know the week when I started isolating Burkholderia capaciae from blood culture, and the change of new brand of soap solution was made. So then we changed the entire soap solution. Then abruptly it stopped. So that is what happened. It happened in 7 years before in our hospital.
All done. Anything changeable has changed. Almost everything in the hospital is new brand, from IV fluid to chemo drug. Anything that is, because we don't know. So anything possible, different brand available, change from A to Z. The hospital, everything looks new. The pharmacy looks new. Yes. Okay. Now, discussion and action, we discussed already. This is the point, friends. The last meeting, all the oncologists, the hospital, with everybody else, every specialty, all the oncologists cancel their clinics, their appointments, because it's impossible to get all the top oncologists. It's a big oncology center, dozens of them on one room and for 1 hour meeting is nearly impossible. But they all cancel their appointment because this is the survival of a center. Everybody depends on this meeting. Everybody there. So we started discussing even before the formal meeting. Then the suggestions came up, Yeah. See, some of the oncologists, we're looking for the differences, So far, we are concentrating more on what the drugs were used for the patients we had the bacteremia. And the patients did not have the bacteremia as a large population. We are talking about thousands of chemotherapy patients. And we started looking for commonality. In fact, we had cultured drugs of the patients who did not have bacteremia to rule out the control group and test group. So many drugs for the patient who did not, these people did not get also cultured. And then suggestion came up. One group of oncologists use ondansetron antiemetic. The other use palnosatron. So immediately, we made them sit this side, this side. Those people use ondansetron this side, palnosatron this side. The discovery, only those use palnosatron had bacteremia. But there are thousands or hundreds of patients who received palnosatron who did not have bacteremia. And we have cultured vials of palnosatron. But this is an important discovery. None of the ondansetron group oncologists, none of the oncologists who use ondansetron had ever had Burkholderia bacteremia. And only those who use palnosatron had Burkholderia bacteria. But there are hundreds of patients who got palnosatron and no bacteremia, no symptoms. But still some clue. We already cultured the vials. All these vials, ondansetron, palnosatron, cultured, no growth. Now, should I go for the breakout room or should we proceed? Now, we pulled out the vials of palnosatron again and cultured. And we had 2 brands of palnosatron, all earlier cultured. Out of the 2 brands, 1 brand grew the bug. And next day, exactly the same antibiogram. But we cultured earlier. We look back, track back. We were sure the earlier batch was same. But then when we look back, not exactly the one ordered brand was not the one given by the pharmacy because that brand had run out of stock that time. So it was given. So even when we track back the check for this that particular day, one particular brand was available. But that was not the one given. It was a different brand given. So when we cultured again, we found out that the batch we cultured was different. There was one brand was unavailable. So the other brand was slowly reintroduced. The slow reintroduction time, number of patients started slowly increasing. So it was a different batch. It was missed because of, even though specifically batch was checked, because when the drug prescription, that's the importance of not just prescription, looking for the indenting. After that, every drug was tracked from, not from the prescription brand, but what was indented. What exactly the patient, that's only available from the bill the patient received, not on the drug chart. So that's one message. When you start investigating outbreak, don't just believe the brand you gave of the drug chart. You should pull out the indent. When you pull out the indent, you have to pull out the indent of the patient who had bacteremia and not had bacteremia. We are talking about hundreds of patients indent and mixing and matching. The IT department, the work, enormous work they did is amazing. It was like a mass data, cleaning out mass data. Without IT, we couldn't have done that. And then without breakout, I'm going, pull the drug from the pharmacy. The whole palnosatron, both brands of Filnodol, so that nobody by mistake should write it. Now what do we do? Friends, we have to inform the Drug Controller General of India. You can't just say we found out and pulled out. You should inform every outbreak drug. You have the legal, moral, ethical responsibility, however risky it is, to inform the Drug Controller General of India. And Drug Controller General of India pulled out the whole batch of the drug from the country. See, now when we talk about drug contamination, however good the company is, everywhere in the world, some batches do get contamination. But the right action is, the moment you discover it, inform the drug controller, not the state drug controller. You have to inform the central drug controller. It's difficult to coordinate between various state controllers. Central drug controller, pull out the whole batch. That's it. Pull out the whole batch. But thank God, palnosatron is used mostly in only oncology centers. So it's pulled out from all the oncology centers. Now, one important thing. So why didn't all the patients who got bacteremia? Now, we had 56 patients, not directly. We called back every patient who received that particular batch and brand of palnosatron. We did surveillance cultures of everybody. That's why it became 56. Otherwise, it was around 40 patients. 26 patients were from surveillance culture who had absolutely no symptoms as far as we are aware. And some of them told mild fever when the line was used. Mild fever, maybe a bit shivering, but settle, doctor. Why are you pulling? Then we pulled out the chemo pot of all these 56. And some of the patients was, why are you pulling the chemo pot out? I'm fine. Why can't you just chemo? But the surveillance blood cultures was positive. Pull out the chemo pot and treat it. Now the potential explanations. Why so many others? None of the patients, only one. Almost all other patients who did not have a chemo pot, even though I received this particular batch of the drug, did not have. Now, Burkholderia cepacia being an environmental bug, needs to colonize the line. The chemo pot lines get colonized. So that's what happened. Some of them had chemo several weeks ago. And then when you use that line next time, whatever you push, the bacteria will be pushed into the bloodstream, produce symptoms. That's when you send the blood culture. That's when it is positive. And then whole genome sequencing was done on the clinical isolates and drug isolates. They were perfect match. Perfect match. Let's discuss now. So what saved the hospital was that final meeting, some off the record suggestions, off the record, just somebody had an idea, you know what, anything can be different, anything can be same. Yeah, this, some of the oncologists we don't use. So we put them in two groups, it perfectly matched. Two groups, haves and have-nots. Now let's discuss. And before this takeaway, stakeholder engagement is very important. Be practical, cost-effective, collaborative, involve everybody from top management to the housekeeping staff. That's very important. The teamwork, the communication, the strategy, thinking, collective thinking, involving everybody. Everybody is important if you are in trouble. Let's discuss. Let's discuss now. Come on. It's 9:59, just over 2 hours of discussion. We can discuss for a long time. This is one of the, in my career, which is not pretty short, but pretty long, this is the most difficult, most important, most challenging outbreak I ever got involved. You won't believe the kind of second, third, fourth, every infection control consultant is now consulted on Zoom. And remember, this was during the COVID time. Not the beginning, but almost the mid to end of the COVID time, the mid of the COVID time. Friends, remember, this is the COVID time. And Zoom was available everywhere. Zoom meetings day and night, Zoom meeting for ideas. No ego involved here. You are in trouble, call everybody you know. Ideas. Starting from young infection control consultant to the very old people in the country. Now give me suggestions. Practical suggestions, practical. Importance of practical, collaborative thinking and hard work. And this will make you humble. Humble. Let's discuss. Everybody.
So how are we going to avoid these kind of scenarios in future? Maybe when we face with this, we have to check each and every drug is administered to patient. Is that one of the key?
That's not possible. That is not possible. We can't culture every batch of every
No,
drug.
that's not culturing. We have to have a look into it, and we have to look into the possibilities, again, commonalities and differences, because which is totally never expected in this case. I never expected a thought of it should be a drug.
Yes, but we had even discussed, thought about commonalities, differences, cultured dozens and dozens of drugs even earlier. But we missed. We missed. By the when the case became some 10, by that time 10, 12, almost every commonality were fluids, looking into vials, haplock, this clock, so many cultures. Sorry, I'm using that word. I'm a bit excited when you talk about the number of samples, microbiology, piling up, even by the 10, 12 patients. But we missed it. And with all the red herrings, gel become positive, the ice pack celebration, everything red herring.
So instead of using these multi-use jellies to single-use jellies.
Multi-use
to single-use jellies. Instead of using these multi-use jellies to single-use.
They were all single-use
No,
only.
we were all single-use except some of the chemotherapy for pediatrics, which is unavoidable. It's very expensive. You can't just take 10 ml solution and one 0.1 1-month-old baby and
Okay, actually, I'm talking about that ultrasound jelly. Sorry.
Oh, okay. Now, ultrasound jelly single use is not possible. You can't open a big jelly and then throw off the rest. Not possible.
So in
and
institution,
it was not and it was single use wouldn't have helped. Even the ultrasound jelly was manufacturer contamination, just like palnosatron was palnosatron was contaminated in the factory, just like ultrasound gel. Well, these are factory. Even the drug contamination is not. It's a factory contamination. Manufacturing batch contamination.
Yeah, the manufacturers don't do adequate quality checks at their end, and
they do. They still miss it. Not all vials were growing. Even all vials we grew, all of them did not grow. And when they do batch testing, we can't test every vial. They miss it.
In our institution, there is such an outbreak. So they tested these ultrasound jellies. So instead of using these multi-use ultrasound jellies, they switched to single-use jellies. So that's why I up to this point.
Oh, wonderful. You've got small bottles. Okay, that's fine. Okay.
Sir, could you highlight about the role of IT involvement, because it is narrowing down to the antiemetic palestron and with that group, but it is not possible in all centers where it is not having an electronic health record system or where the IT is not up to the level.
Yes, ma'am. Even with electronic health records, the commonality, see, we are not talking about the just patient with the bacteremia. We have to look into data of hundreds of patients who did not have bacteremia. We are trying to differentiate the haves and have-nots. The have-nots was most difficult. Hundreds of patients during that period who did not have bacteremia. And the kind of drugs received, the ward movement, the bed movement, everything is there to compare. The ward movement, bed movements of all these patients. It was a massive, it needs a real AI. Of course, we don't have that AI support at that time, but many IT data and then manually look into it.
What about that first case who came to the hospital from the other hospital?
Wonderful
Had
question.
a pandemic, that same drug?
Yes. Now I will tell you. Okay, that's we should discuss that. Now, what we did was, initially we all thought it's a cross contamination from that patient, index, so-called index patient, isn't it? Then that patient had received the drug, but then we thought that patient had bacteremia, Burkholderia in another hospital. We called that hospital and asked them to send the antibiogram of their culture rate. Antibiogram was different.
Oh.
That was the biggest red herring. The so-called index patient who had Burkholderia here had Burkholderia there and cleared. When we called, we asked the microbiologist in that hospital send us when we got this later. It's different antibiotic. Not a great difference, but different. There was significant difference in phenotype.
For the same
So
antiemetic use? Same antiemetic use there, sir, by any chance?
Their hospital, we don't know. But, we don't know.
Okay.
We don't know. We can't call. They don't disclose the batch of. No hospital, private hospital give you exact batch details. So we can't. We have to check. We confidentially check so many hospitals, okay? Confidentially. But we can't officially ask other drug the batch. They won't give that. They're not bound to give.
Sir, what was the take on the hospital administration with reference to the drug?
What was
the drug lots and batches were growing Burkholderia after identifying it. The antiemetic.
One particular batch of one particular brand was growing. The drug, the same company's another batch was available. That was not growing.
So the hospital didn't ban or withdraw the agreement with the company, or so they continued the brand.
You can't. No, for some time, yes, we do with a drug. For some time, we withdrew everything. But let us remind that however good a company is, some of the batches do get contaminated. It happens, every company, everywhere in the world. But what a good company does is, the moment DCGI is involved, company is involved, withdraw that the company did very well. Every batch, every vial, every hospital was immediately withdrawn. That's what companies do. Drug contamination happen everywhere in the world. However good, these are all excellent companies. But some of the testing misses. Some of the batch testing misses. So possible explanation was, the contamination was very low at the time of manufacturing. Very low. And the drug multiplied over the time in the vial. Some of the vials. Where the initial checking was missed. Because that's also another explanation. Now let's the most important part. Several other patients without line had received the same antiemetic. They never had symptoms. They never had bacteremia. That means the contamination the level was not high enough to be detected at an earlier stage. Otherwise, we'll be having hundreds of patients with the Burkholderia in the blood. Only those, except one. All others had a line, but the drug was given to so many others. Same batch, did not have, but the lines one had.
So it was colonized in the lines?
No, earlier. The drug was given earlier. Most of them had the chemo along with this drug several weeks ago. Some of them very recently. The drug was introduced through that. Line got colonized with the drug, started multiplying. Then whenever you use the next line, whatever may be injecting, maybe saline, maybe Heplox, whatever, the bug is being pushed into the blood, bacteremia. So that's why a lot of them were grown only in the surveillance culture. These 26 patients are absolutely asymptomatic. We call back dozens of patients who got this drug with a line. So we knew the combination, one particular batch of one drug and the lines. We called all of them back, cultured all of them, and 26 became positive, line pulled out. They did not have symptom. Or maybe looking back, they told, yeah, when the line was used in between, I had a mild shivering, but settle, doc, why are you pulling my line out?
Is there a possibility of spontaneous clearance, sir, for people who are in the asymptomatic
group? Majority, yes, because they did not have line. So they didn't have a line to get colonized. You know? So the bacteremia got cleared because the contamination was very low.
Otherwise, the case load numbers, as you said,
would have been a huge number. Hundreds. Yeah, it would have been hundreds. So that's another point. Even those, that is again put us into trouble. Even when we look to the commonality, we have analyzed this drug, but it was not common because when hundreds of patients receive a drug, one batch, and the no symptoms, don't you think we'll miss it?
So we have to involve IT department when there is an outbreak.
Yes, yes. IT is very important. Team, not just few members, lot of IT members.
Sir,
And they have
one
bull-
more doubt. I don't know whether I am right or wrong. These non-fermenters, apart from the colonization from the IV lines or whatever it is, do they have any predisposition for gut colonization and then for invading into the bloodstream by pathophysiology mechanism?
Yeah, good question, ma'am. Ma'am, as you know, non-fermenters are not usually colonized in the gut. Now, if you look at the Pseudomonas, rare. So look at Pseudomonas data. Maybe upper respiratory tract, of course, they are aerobic. All the non-fermenters, as you know, all aerobic. And up to 10% of the patients could be colonized in the upper respiratory tract, so upper GI tract with a Pseudomonas, but only 10%. So majority of the patients, as a rule, non-fermenters are not the gut colonizers, unlike our Enterobacteriaceae. It has to come from outside, whether in ICU or anywhere. A non-fermenter bacteremia has to come from outside, either through a lung infection or another instrument infection, not from the gut.
Sir, what is your take? All these study patients, blood culture was our main prime focus. Were there any other cultures from these patients which had a growth of Burkholderia, for example?
Yeah, some of them had a chest infection as well.
Okay. Because during the breakout room session, I was going through a random view of one literature. It was close to the discussion we had. But apart from blood, they had studied other cultures. But practically, it's not feasible, as you say, sending all cultures, and it's we will still more be in a confusion then.
Yes, ma'am. Agree. But very few patients with pneumonia, but very few. So that source pneumonia to bacteremia was ruled out in the beginning itself.
Okay. Sir, what is the role of this multi-locus sequence typing versus WGS in the epidemiological confirmation?
Okay, now I'm not the right person to comment on that, but if you have the whole genome sequencing, you will get the same MLST in the whole genome. But whole genome is very expensive. So if you don't have the resources for whole genome sequencing, you just do the simple MLST.
Fine, sir.
Because anyway, when you do whole genome, as you know better than me, you'll get the MLST as well from that. Or whatever data you get from MLST. I mean, the data you get from MLST.
The microbiology lab has to store all these isolates for any future reference. Do they have facility for storage?
They have stored. Even the drug sample, clinical samples are still in the microbiology laboratory, frozen.
So is there any stipulated time, sir, because this is pertaining to NABL, I have to do a workup later. Just for getting your experience at your center, I am asking this question.
I'm not aware how long, as a microbiologist, you will know better than me, how long we have to store the samples. I'm not aware of that.
Ma'am, these are outbreak isolates, I think. NABL shouldn't really be concerned about it. So you
it's
can
an
take them for
institutional
academic
policy.
purpose and for further research purposes, but NABL shouldn't really be concerned about your outbreak isolates here.
No, that's what I wanted to know. It's an institutional policy for retaining for future research and comparison purposes.
For research and academic purposes, you can keep the isolates stored with you.
Thank you.
Anybody else? It's 2.5 hours of discussion, but the case is worth it.
Burkholderia is a nightmare, sir.
It's a nightmare.
There were two, one from diltiazem and the similar palinosetron, sir. It was the same oncology, exact same scenario. It was nightmarish.
Yeah.
Very interesting.
Good. Should we call it a day? All of you?
Yes.
I don't know how many people are there. Oh, there are still very active. Divya Joshi is there. Dr. Prerna is there. There are more people still. I thought all of you had left. Ashok sir is there. Arya is there. Now everybody is putting the camera on. All those present, can we put the camera on? Uma ma'am there. Yes, of course.
Actually, I highlighted the point point of
Just
product
use the-
comparison in the adult unit.
Ma'am?
Actually, during the breakout room session, I highlighted the point of product comparison.
Yes, ma'am. Very good. Very
It
good point.
finally got emphasized at the discussion, sir. Fine.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you. Yes, should we call it a day?
Yes, sir.
Thank
But
you.
the
Thank
entire
you.
duration, sir, the entire duration of this case from August till how
3
long it went,
months,
sir?
2.5 months, 2.5 months. But it's all happening. Initially, okay. Now, when I come back, I didn't put the graph. We are going to publish this paper. It was very, very sporadic in the end. And out of 40 initially, 26 are surveillance. Very,
Because
very sporadic. There were
You
only 4
highlighted
patients.
it was during the COVID pandemic also.
And no, man, it's still everything was done from the beginning. In the first 1 month, first 6 weeks, there were only 4 patients. And then last 2-3 weeks, the big shower came. You know the reason? The other drug batch was slowly becoming introduced. The first batch was disappearing. The other batch was getting introduced. That's why the case number was increasing. That was the reason. It was no patient-to-patient spread. The more of that particular batch of that particular brand is introduced, the more numbers start appearing. Even though there were 56, some 26 are surveillance callback, some 40, majority of them, 2/3 of them appear in the last 3 weeks. The nightmare time. The
Yes, sir,
duration
yes,
may
sir.
be 2.5 months. That's important.
Yes,
You know,
sir.
some of the nightmare last, making you sleepless for months.
That's why I asked how much long was this issue.
The last 3 weeks were the one that made us sleepless. All of us. Sleepless. You'll understand the hospital recognize how important infection control team is to the survival of the hospital. That's the importance of the strategy course, friends. Infection control consultants believe, some of them when I told, why should this course be charged? Why can't it be free? I don't have the money, even it's a low cost. You know, I'm just discussing. If we infection control consultants believe, can you hear me?
Yes, sir.
Infection control consultants believe even a course is not worth. We are not worth hospital. We are the most important people for any hospital. No hospital will get accreditation without infection control consultant. Every hospital will get accreditation if you don't have a cardiothoracic surgeon or a neurosurgeon or an oncologist. No hospital will get accreditation without you. And if you don't consider you are worth it, nobody will consider you are worth it. What we need is that self-realization, a self-worth in every way, financially, professionally. So this case proves how important we are to the hospital, not just accreditation. The hospital cannot survive without us. We are the most important people for every hospital. We should realize that. Next time when you go back to the hospital, you should ask for a salary rise. A salary rise.
Hopefully so.
Is that a good message?
Yes,
That's
sir.
the purpose of this course.
Absolutely.
That's why from the beginning, this is not a theoretical infection control course. This is a strategy course. And one of the most important strategies to convince everybody how important we are. Next time the neurosurgeon should come and, you know, touch your feet when there's an outbreak. Not to that extent, though, but good night. Hope we had a wonderful discussion. We'll have more,
Yes, sir.
you know,
Good night, sir.
may not be as adventurous as this, but we'll discuss all the important scenarios. And week by week, case by case, we'll convince ourselves the importance of infection control and collaborative work. Everybody, economists, epidemiologists, ministers, bureaucrats, we'll discuss more of pandemic cases, epidemic cases for public collaboration, not just in the hospital. It's a big field. Good night. Thanks a lot for participation and wonderful participation. What an active participation from all of you.
Thank you, sir.
Dr.
Thank you
Divya.
so much.
Thank you.